Good evening and welcome. I am Brother Dr. Jeffrey Sterling, the Surgeon General for Alpha Phi Alpha Fraternity Incorporated. It's a pleasure to be with you this evening. This is a special edition of the Surgeon General Initiative webinars, and on behalf of our General President, Brother Lucian Metellus, and our Board of Directors and the Deputy Surgeon General, I want to welcome you to this conversation. There's so much happening in the news that we felt it appropriate and necessary to really distill all of that information and just bring it to you in ways that would be easily understandable and would empower you to take action and to be aware of what you need to do in these turbulent times of ours. So with that in mind, I want to introduce our panelists for this evening, which just happened to be our public health guys. I would include myself in that, obviously. So bring both of our panelists, please. And we have Brother Dr. Okienya, who is our Deputy Surgeon General for Healthcare Disparities, and our good brother, Dr. Robert Carter, who is our Deputy General for Public Health. As opposed to what we usually do, and because of the nature of what we're doing today, I'm going to let these two brothers introduce themselves because they're so dynamic, and it's such a pleasure for me to have the public health team on board to engage in this conversation that I actually want to start. We have about 10 topics that we're going to run through, but I just want to start by letting these two brothers just take a minute each and talk a little bit. I know that's impossible, but let's do it. Talk a little bit about what you do and what you're going to bring to the conversation this evening. So let's start with you, Brother Carter.
Thanks, brother. It's truly a pleasure to have an opportunity to discuss these important topics tonight. Again, I'm Brother Dr. Robert Carter. I have served in a variety of roles in the federal government, as well as a public health advisor for large non-for-profits, and also as a professor of public health and biodefense. And so really excited tonight to have this conversation on public health. Is at an unprecedented time in our history, and it's topics that we really need to discuss so that we can better prepare our communities for what they might face. So again, thanks, brother. Look forward to the conversation.
That was a very modest conversation. I want you to talk about what you do professionally. I mean, I want people to understand the magnitude of who you are and what you do and what you're bringing to the table. Come on now.
Yes,
Don't
yes.
be shy.
Yes, sir, brother. So I'm actually a colonel in the U.S. Army, where I've been involved in various medical countermeasures. I've worked for the last really 25 years, really across the sectors, both educating our future generations about public health. I've served as a professor of emergency medicine at the University of Texas Health Science Center. I currently serve as a full professor adjunct in the biodefense program at Northeastern University, and also with the Chicago School, specifically in the Master's of Public Health program, focused really on developing public health leaders. So again, this is an exciting time, and I'll talk more about myself as we go along. But again, just happy to be part of this esteemed panel as we engage some important topics. Also, specifically on the non-for-profit side, I was fortunate to advise two large non-for-profits as they navigated the pandemic, and working on really both sides of the fence, as well as advising within the federal government space. So look forward to the conversation.
All right, there goes an alpha man. Thank you for that. And next up, certainly last but not least, good brother Dr. Okienya. The floor is yours, sir. Welcome.
Thank you so much for having me. I am Brother Dr. Okienya. My background is medicine, public health, health policy, politics, research, and teaching. I'm a former House and Senate staffer on Capitol Hill. Then I did some work at the Department of Health and Human Services before going to DC government, and then going into the not-for-profit sector, where I currently serve as Associate Vice President for Federal Government Relations for the National Multiple Sclerosis Society, where I lobby on behalf of the over 1 million patients that live with MS across the country. As far as my research is concerned, my study was first of its kind to examine the Affordable Care Act and its impact on access to care for Black men. I have a doctorate in health policy from GW here in DC. Um, a few key findings from my study are that Black men were 30% less likely to be insured compared to white men, and Black men were 25% less likely to have a regular doctor to go to compared to white men. And so part of what I'm doing now to build on that study is to operationalize my background. And so, for example, last fall, when Vice President Kamala Harris announced her intention to stand up an opportunity agenda for Black men, I decided to do a brain dump that encapsulated my background and experience in terms of government, policy, politics, research, um, and advocacy. And so, as a scholar activist and a policymaker, um, I, I I drafted up what I'm framing as a John Henry Health Equity Playbook, a 4-year health policy agenda for Black men. And so, as someone who works at and has worked at the local, state, and federal levels, my goal was to fill the significant gaps that I found in terms um, of educating the general public on ways to shape policy. And so, part of my playbook and my second book actually is going to focus on helping people shape policy at the local, state, and federal levels. And so I'm thankful for this opportunity to share my experiences, my expertise on this august platform on behalf of the brothers of our fraternity and the public writ large.
Outstanding. Thank you for that. And once again, two of our deputies, Surgeon General, absolute pleasure to have you this evening. Let's get into the conversation. I'm going to start with a more broad topic, and then we'll get granular as we go. But as you all know, there have been about 10,000 scientists and other career professionals who have been cut from the various departments under the Department of Health and Human Services, including the CDC, Centers for Disease Control and Prevention, and the FDA, the Food and Drug Administration, in the name of efficiency. We've heard about the cuts, but we haven't heard about the efficiency, just on a global scale. Gentlemen, and I'll start with you first, Brother Carter. Talk about why these cuts can be a good thing or can be a horrible thing, and why you believe they're either a good or a horrible thing.
Yeah, no, brother. Thanks for that question. So first of all, when you look across the government, across the agencies, what important thing to recognize is that there's this aspect of interagency where various departments actually work together to provide a whole of government approach to address whether it's a pandemic or just ongoing chronic disease or other issues related to health as it impacts the nation, veterans, and other individuals within our community. So when you begin to take cuts or instrument efficiencies without necessarily having a comprehensive strategy on making cuts, then it can create gaps in the overall ability of the federal government to respond as a whole of government. And when you look at the construction of our government, it's really designed to be able to address whether it's the Department of Commerce, Health and Human Services, the Department of Defense. It's a whole of government approach. And so we really saw that play out during the pandemic, where each of these levers within the government were exercised in order to provide a comprehensive response. When you look at HHS is one of the largest bodies within the government that specifically focus on critical research, both externally, outside of the government, providing funding through a competitive process so that experts throughout the country, academic institutions, non-for-profits, large hospital systems can collaborate with scientists within the government. And so when you look at that overall process of providing the best science, going through each federal agency has a strategic plan, meaning it's a 5-10 year plan where each of them are charged with with achieving certain initiatives. So we think about like the Healthy People 2020, Healthy People 2030. All those have specific objectives that, as a nation, they're paused to actually address. And so when you begin to basically decompose that overall system that's charged with addressing those, you can create some challenges and some larger gaps, whether it's health disparities or the ability to respond to an outbreak or just the ability to actually achieve the health of the nation. And so when you look at you could take deliberate, for example, if you look at to say, okay, maybe there are specific objectives that have been achieved, or the approach that we were taking to achieve that particular objective. Sometimes it's good to re-examine those, and sometimes you do actually have to make a shift towards re-examining. Have you been basically taking the right comprehensive steps to, for example, reducing prostate cancer deaths in African American men, or whatever that topic might be? And so sometimes it's actually good to look at your overall strategic plan, but you have to do it in a very, very deliberate way. Okay, so again, the way the cuts are being delivered could again lead to current and future downstream risk, unintentional consequences.
No, let me redirect that question to you, because there has to be some logic behind the cuts. I mean, theoretically, unless we want to be contrary and just say this is something other than, I mean, let's give the benefit of the doubt. I want you to tell me in a sentence or two, a paragraph, what's the idea? How do we create? What's the idea behind the alleged efficiency of this all? Come back to me on that, Brother Carter.
Yeah. So again, it's when you look at it with the approach that's being taken, is not necessarily aligned per se with achieving those strategic objectives. So again, cuts for the sake of cuts, will have dire consequences that we'll have to reconstitute. So again, this particular exercise and by the administration is really focused on reducing ultimately the size of the federal workforce, without necessarily looking at the overall performance of the federal government to address what it's charged to do.
So perhaps what I'm hearing you saying is that, and what the people out here should understand, is that the hierarchy of reducing the size of the federal government is being placed as a higher order consideration than the outcomes that are produced by interagency interactions. Let me move over to you, Brother Enya. You want to answer that same question and give your thoughts on all that's been said so far?
Yes. So I'll give from a policy implication perspective, I'll just choose 5 out of the plethora that I could talk about. But just in terms of public health preparedness, the reduction in CDC personnel and programs will impair the nation's ability to respond effectively to public health emergencies, obviously with COVID, with measles, right? And so that's one plank. Another is having the regulatory oversight to approve drugs, to ensure that foods are kept safe. Those things are important to think about when we're talking about cutting staff. Mm-hmm. Obviously, research and development, right? So when you are cutting much needed critical funding to the NIH, CDC, other bodies, that impacts patients in disastrous ways, I would argue. Scientists are hired to come up with world-changing cures and treatments and modalities that are literally saving lives. And so when you cut access to those sources and resources, the downstream effects are disastrous. And we can talk for hours for that. But and then obviously health equity. we know that when a targeted, focused approach to supporting and putting in place interventions that support the least of these, the impact of that targeted, focused approach elevates and helps entire populations. Um, and so that needs to
Hold
be.
on. Let me stop you there. No. Hold on. Let me stop you there. Because with the government's assault on DEI,
Mhm.
typically when you have healthcare policies being developed, there's two approaches. It's how to raise outcomes across the population on one side of the coin, and on the other side of the coin, there's dealing with the least of us, as you so eloquently said. Are you aware of the assault on DEI eradicating or being anticipated to eradicate initiatives such as the Office of Minority Health or other initiatives that would deal with that half of the conversation?
Yes, yes. So it was about maybe 2 or 3 weeks ago where the Office of Minority Health and anything that was minority related were also decimated, were cut cut down. And so again, when you intentionally attack and dismantle systems and structures that have been thoughtfully put in place to address the structural racism that has shaped the entire American healthcare system, you will see the impacts in terms of more deaths, more comorbidities, more negative health outcomes. And to even take a step back further, look, I am an ardent student of history. And when you look at what's happening from a historical perspective, we know that whenever the nation or Black and brown people have made progress, there's been that backlash or that pushback. And
Yeah.
so if we know that that is happening, part of my passion is to be forward thinking and to be future focused, to say, okay, we know that it is inevitable that if we put health equity related systems in place, that there is going to be some backlash. So how do we get to a place where we are being proactive in civic engagement, where we are being proactive in my case, what I'm doing is, as I noted earlier, drafting up a health policy, health equity playbook that can be leveraged at every level of government, and actually equips people with the tactics and strategies that can help to push the needle when the pendulum swings back into the left part of the political spectrum.
Okay. Um, See, my way of thinking about this is pretty straightforward, and I'm going to give a short answer. Structure allows function. And when you have a scenario such as we have now, where there's decreased reporting on issues such as alcohol related death, asthma rates, cancer rates. These are actual entities inside of the government that have now been eliminated. Reporting of cancer rates in firefighters, reporting of rates of carbon monoxide, radon, other dangerous chemicals, reporting of HIV positive individuals who take suppressant medicines, and on and on and on. How can you develop accurate policies to address when you don't have the epidemiologic information to know what to prioritize? These are problems, and there's not a level of efficiency that we've seen that would suggest that we're going to be in a situation to address this. And I say that so that when these epidemics or problems occur, you can draw that line, folks. And it's really just that simple for me. I'm going to stay with you on this question, Brother Enya. The next question. Let's talk about the initiative. Utah actually just passed a couple of laws statewide, and one of them was regulating food in public schools that included a ban on the specific use of dyes and chemical additives in public school meals. Good thing, bad thing? You want to comment on that?
Yes. So I am of the persuasion that I believe in science, and I also believe in incorporating the voices of people with lived experience to be able to help shape policy and science. And so when we're talking about food safety, I err on the side of trusting the experts to help and working alongside parents and teachers and faculty and staff to come up with policies that incorporate as much good guidance as is possible that is rooted in science. And so that's where I land on that.
Did we lose Brother Enya? Why don't you go ahead and jump in, Brother Carter?
Yes, again, I actually wrote a book actually along this topic, specifically on adulteration of food and basically how it impacts health, and have actually published some work in that regards. I think, again, we know that a lot of the dyes that are actually put in food can contribute to negative outcomes. We know that they have been linked to certain types of cancers. So some of those initiatives along those lines could yield positive outcomes. But I think, to your point, without actually having the epidemiological data to basically support those changes, we won't necessarily be able to capture what some of those changes might lead to. Again, go ahead.
No, I'm going to redirect because I think you both have answered the question. The point to be made is that nobody is studying this, guys. This is already passed in Utah. It's already passed in Indiana. This is happening. My question to you, is this a good thing or a bad thing? Because the point I want to make to my conservative friends is that, when Michelle Obama proposed this a few years back, you were talking about butt freedom, and I deserve the freedom to have my French fries, this, that, or the other thing. And now, quiet as it's kept, although RFK is very much in the bag for the president's policies, he very much, in some of his thoughts, not all, represents about the least conservative considerations in this administration. So my question to you really is a pretty straightforward one, based on the evidence that exists. And I'll come back to you, Dr. Enya, you were cut off. Based on the evidence, is this a net good thing or a net bad thing that we are promoting food safety at what would be, from the right, claim to be a loss of freedom for people to eat how they choose, even when you're talking about children?
It is a net good thing. Look,
Okay.
Last year, Governor Gavin Newsom signed Assembly Bill 2316, the California School Food Safety Act, which prohibits public schools from serving foods containing the 6 aforementioned dyes, right? And that law goes into effect in 2027, which aims to protect students from the chemicals that have been discussed. And so, look, it's the similar argument when we're talking about masks, right? So we know, and science can support the benefits of wearing masks. It's not to restrict your freedom; it's to keep you and others safe and healthy. And it's a similar argument that's being used about food safety. And so that's where I stand on it.
Okay. Real simple. Speaking of simple, is the country over or under vaccinated? And you can go wherever you want to in that question. That's a loaded question that either of you could take in a couple of different directions. Let's go to you, Brother Carter.
Yeah. So in general, when you look at vaccination rates, whether you're talking about Pneumovax in the elderly population, is generally lower than what you would like to have at the individual protection level. When you look at flu vaccinations, generally each year, definitely the country would benefit from higher rates of influenza vaccination. So in general, there are certain populations, certain communities for sure are undervaccinated, but there are populations that's probably right at the right level. But again, when you have variations in the amount of vaccination, as we're seeing with the population in Texas with the measles outbreak, that didn't lead to disparities. Individuals dying or suffering a higher morbidity mortality rates as a consequence of being unvaccinated. So I think it's both, but in general, unvaccinated.
Yeah, I saw you hedging there. I'm going to come back and pin you down on that question, but I'm going to get Dr. Enya to weigh in on that first. As a global consideration, or is this country under vaccinated or over vaccinated?
This country, I would argue that this country is under vaccinated.
Okay.
And so routine childhood vaccine rates have actually decreased since COVID. And in fact, when we're talking about taking the pneumococcal vaccine for adults, only 22% of adults age 19 to 64 who are at increased risk have received at least one dose of that particular vaccine. Um, and so there's actually um, a decrease, and part of it I would also argue is because of vaccine fatigue. Like COVID really exacerbated um, much of the fatigue regarding the critical importance in my book of getting vaccinated. And so even as we're talking with measles and in Texas and other states, the narrative is not helping matters in terms of the critical importance of getting vaccinated.
See, this is where I come in on this, guys. And I respect both of you so much. And we don't have this part of the conversation enough. There are actually effective ways to avoid these diseases without vaccination.
Mhm.
So let's not pretend that vaccination is the end all be all. What we tend to not speak about is the reason why we promote vaccination to with such veracity. We do this so that those individuals who cannot get vaccinated, people who have actual allergies or who have immune circumstances that preclude them from getting vaccinated, will be protected. And the drop in vaccination rates that you cited actually portends ill will toward them. We've now become a nation in which we are no longer willing to make that small sacrifice to protect ourselves for the greater good of protecting those that otherwise are left vulnerable. The demographics, the epidemiology of those who died in COVID were the bullseye squarely were on people who were the most vulnerable, whether through their demographics, their disease and immune status, or those who just chose not to get vaccinated and had adverse consequences from the disease itself. So to say that we are over or under vaccinated, we have some of the highest vaccinations in the world. And somebody could say, well, how can you say you're under vaccinated when that's the case? But the truth of the matter is that either we're a country that looks out for each other in this regard or not. And I think that we pretty clearly are showing in an increasing manner that it's not about the greater good of the society, and that is part of what is eroding at the concept and implementation of public health. Let's stay on immunizations for a second, and I'm coming back to you, Brother Carter. Measles. Why is the conversation about measles so important for a disease that's only, and that's very much in quotes, killed 3 citizens so far? And this kind of piggybacks off of what we were just talking about. So why are we making such a big fuss over 3 deaths to this point?
I think those 3 deaths really just represent, in public health, as we often talk about the canary in the coal mine. I think it just highlights that the impact of under-vaccination, as I mentioned before, in specific populations can lead to outbreaks. And most importantly, we know that in that case, by having herd immunity, having 90% of the population vaccinated against measles, can minimize and reduce outbreaks such as measles. And so again, those 3 deaths are truly preventable by ensuring that we have folks that can get vaccinated.
Okay. I'll toss it over to you, Brother Enya.
Yeah, so measles are amongst the most contagious issues or conditions that impact about 90% of unvaccinated people who are exposed to the virus. And so so to the earlier point, thinking about ways in which we could better protect ourselves and others, um, this is an example of why it is critically important in this case to pursue the MMR vaccine. Um, this year alone, over 700 cases have been reported across 23 states. which is more than double the total from last year.
Mhm.
And so we want to be thinking about why that is. What is happening in the context of the social and the political drivers of health as well, to really get at why we are where we are with this particular issue. So that's kind of what I would share on that front.
Okay. See, let me go off script, as I am wont to do. Let's look at the quote word that I threw out there. Only 3 citizens. See, 3 citizens is 3 more than should have ever happened. But I think it's very important that we have this conversation now, and that is to interfere with another conversation that is trying to emerge. There are those that want to eliminate vaccines across the board for their children. And if that train of thought were to occur, this country is still in the low to mid 90 percentile amongst the childhood vaccinations, largely because it's enforced during the school years. However, if that protection were taken off, as is being advocated by some across the political spectrum, that number of 3 would become hundreds of thousands of deaths. Only 1 per 1,000 individual who actually is vaccinated is going to die from the disease. And we've done a decent job at keeping it at 3, even in these turbulent times. But if we listen to the nonsense that's out there, and with all due respect, it is nonsense in terms of the viewpoint of public health, that number of 3 could be several thousand folds more than it is. And I think that's why the conversation from my perspective is so important. Let's keep it moving. Robert Kennedy Jr. Just mentioned that there was an autism epidemic. So I'm just going to give you guys a softball. I know you guys both are ready to knock this one out the park. Can you please explain to the public why there are more diagnoses, and talk about the difference between there being better surveillance of a disease versus there actually being a higher incidence of the disease? I think we're going to stay with you on this one, Dr. Enya. Let's let you start on this one.
Yeah, so some factors that are contributing to what is currently being framed as increased diagnoses, which I think there is a valid point there. And so the recent expansion, so the expansion of the diagnostic definition of autism, particularly with the DSM-5 in 2013, what that did there was to consolidate the various subtypes that fall under the autism spectrum disorder view. And so probably when you open up the aperture to incorporate more kind of variations in the ways in which autism is defined, that as a consequence will cover more people, which will show up in the increased numbers that we're seeing. And then also, based upon the American Academy of Pediatrics, they also recommended a universal autism screening at 18 and 24 months. And so that has increased the early identification rates. And then just in terms of what's in the narrative, so the increased public and professional awareness of autism. I think because it's in the ecosystem and it's being discussed more, that raises the awareness about, okay, should I get my child screened? And then the next thing is, how do we now, kind of think through all of the issues that are impacting the causes behind autism. And so those are just a few things that I would kind of pull out there in terms of factors.
So what I hear you saying is that the diagnostic categories for the entirety of the spectrum have increased, which has led to increased diagnosis, as well as a sensitivity to the set of disorders themselves, which has led to earlier screening and thus greater diagnoses. Did I get that right?
Yeah.
So, brother Dr. Carter, let me toss the second half of the question to you. There have been implications that there are things such as vaccines and other causes that are avoidable that have contributed to the increase in autism diagnoses. Are you aware of any research anywhere that supports that notion?
No, brother. In fact, a lot of that research was done by a scientist that was later found to have fraudulent research. But unfortunately, when parents of kids with autism are looking for answers, vaccines really became a target specifically. But I'll add one aspect. There is some evidence that autism, independent of increased definition and awareness and populations that historically have been underdiagnosed. And part of that is at least some evidence that there may be some environmental factors that have actually increased, as well as older parents. We know older parents have some increased risk of certain types of conditions, specifically passed on in kids. So but again, that will contribute to a much smaller real increase. But as brother pointed out, much of that has basically been a broader definition. But again, there isn't any scientific evidence. You'll find some actual papers in the literature that have actually done some epidemiological analysis. Many of those papers appeared in lower tier journals, but often are used to basically provide provide analysis that this relationship between autism and vaccinations is real. But again, when you look at those specific few studies that have actually been published that show that relationship between autism and vaccination, many of those were actually flawed study design, specifically as they attempted to pool studies. And when you look at it, it was small populations that were pulled together, and that really led to some biased outcomes.
You're being very diplomatic. I think it's fair to point out that one of the scientists who was a physician involved in those studies actually had his medical license pulled. And another example, one of the scientists who participated in that fraud actually was prosecuted. So those data were completely fraudulent. Guys had financial ties with entities that were suing. There's a lot to it. But one thing that you said, and I'm going to invite our listeners to Google the word eugenics. One thing that you said that is important to understand and we need to be very much aware of is that the data is showing that one of these, it's actually not an environmental factor, but a genetic factor. Genetic factors actually appear to be the overwhelming contributor to individuals who later come up with that diagnosis. And as RFK has said that he wants to eradicate the cause of autism, if you take that at its word, there's some pretty sinister implications for ethnically cleansing and breeding and other such things. I'm not going to climb down that rabbit hole tonight, but let's see where the data takes us, because as it stands right now, there's nothing, and we can simply leave it at that, nothing to suggest that vaccines are contributing to autism. All right, next up, continuing on with some of the things that are part of the Make America Healthy platform and something else that was just done in Utah. I'm talking about fluoride in water. Is this something that represents a passive public health protection effort, or indeed, is there any real increased risk to doing this, even though we've clearly been doing it over 100 years? Who's up next? Let's see. Let's start with you again, Dr. Carter.
Yes, again, thanks, brother, for that one. So when we look at the amount of fluoride specifically in water, it's been well documented. The amount of fluoride, 0.7 milligrams per liter, is about what's needed to specifically provide protection, specifically from tooth decay. And we have to remember that fluoride is actually a naturally occurring mineral in water, soil, and some foods. But by calibrating it and providing that appropriate level, it does provide provides protection against tooth decay. It is not just tooth decay. We know that poor dental hygiene, as our Deputy Surgeon General for dental health would articulate very well. But again, poor dental health is also tied to cardiovascular disease and a wide variety of other conditions. So it's not just the dental health that fluoride is actually protecting, but it's the overall physiology of the human.
Very well stated. Brother Enya, you want to add to that?
Yeah, I'll add that that the community water fluoridation process is recognized as one of the most effective public health measures for preventing tooth decay. In fact, according to the CDC, fluoridated water reduces cavities by about 25% across all age groups, and this benefit is actually even more critically important for children aged 0 to 8, because the fluoride helps to strengthen tooth enamel, and also for older folks who are more prone to tooth decay. It also helps to address any health issues, as was stated earlier from Brother Carter, about that can impact that patient's health. And so, even from a cost perspective, if we know that if we take a preventative approach, and again, really ensure that we can meet people where they are, low income, children of color, patients of color, then that also will save billions of dollars in dental treatment costs.
Yeah, I just want to reaffirm something you said. The CDC actually identified this passive public health prevention as one of the greatest innovations of the 20th century. And this is a great story. I'll take liberty here and just point out that while the rest of the country in the early 1900s was walking around with rotted teeth, literally, Colorado was the place where this was discovered, because it occurred at those natural rates in their water. And after it was studied, it was discovered to be a good thing in the ways that you both have described. One other point that kind of needs to be made: in the effort to remove fluoride from water, we should be aware of what's at risk here. People are a lot less likely to drink water. And even if not water, that same water is included in soda pop and other fluid juices, or whatever the case may be. And if you remove that from the water supply, that means that we're going to pretty much be relying on people brushing their teeth and having access to dentists and others who would ensure appropriate oral hygiene. That is not a safe bet. And as healthcare disparities waiting to emerge. So let's kind of keep that in mind. And if given the opportunity, let's continue to advocate for keeping that process in place. It'll be studied. If the studies are honest, then they'll show that this is a good thing and not at all unhealthy.
Yeah, brother, I want to make one quick point on that, that we didn't touch on as important. When you look at the rise, most Americans don't drink tap water. And so when we look at their studies documenting the rise of bottled water drinking, specifically among younger populations, that we're seeing that rise in tooth decay, hence why it's critical for folks that drink a lot of bottled water to use toothpaste and mouthwash that contain fluoride, and ensure that they're doing their annual dental checks, and they get a fluorine rinse. So I think that's an important aspect of it, because again, that's good evidence, right? Good epidemiological evidence to show that fluorination works, because we can see populations where it's not working.
Well, I do want to rebut just a touch, because I chuckle whenever I think about bottled water versus tap water, knowing that about 64% of bottled water actually is tap water that's been run through a filter. But your point is important and is on point. So let's continue on. I like this topic, and I'm going to take my foot off the accelerator for just a second, because you guys are too good not to get. I'll give you an extra minute each on this conversation. This country spends more money than anybody else in the world on healthcare. And when I say on healthcare, I mean the healthcare industry, not the healthcare system. Those are two completely different things. 21% of our gross domestic product and $4.8 trillion a year. You would have to believe there's some room for something to be cut, especially when you consider that our healthcare outcomes are not close to being the best in the world. As a matter of fact, we famously tout out the studies that showed that we were in the mid to lower 30s in terms of systems. And a lot of that has to do with the fact that we don't have universal healthcare. So I'm going to ask you guys this question. If we were if we were being sincere about creating efficiency in healthcare service delivery, how could we cut costs instead of just slashing and creating more disparities, less access to care? Let me start with you, Brother Enya.
Yes. So I have 5 or 6 things that I'll just name quickly. So one is food as medicine. Food as medicine. So using medically tailored meals, and which have been found actually to reduce hospitalizations and have and could potentially save $32 billion per year annually if taking a medically tailored meal approach was actually pushed forward, as opposed to claiming that there's a plethora of fraud, waste, and abuse, which is a whole nother conversation, right? But there are over 14 million Medicaid or Medicare beneficiaries that could benefit from having a medically tailored meal approach or program kept. And then secondly is, how do we integrate care for high need populations, right? How do we take a whole person care approach? Because there are models out there. California has a whole person care pilot that has helped to coordinate housing and behavioral health support that could reduce ER visits and hospital hospitalizations, saving about $383 per patient annually. And then we're talking about and then we can talk about managed care and value-based payment models, which over the past decade to 15 years, the transition from fee-for-service to a value-based payment model has also been found to help to improve health outcomes. And so and then again, the past few, well, probably maybe Biden, in terms of home and community-based services, and so the American Rescue Plan had a plethora of sections that would support HCBS, because it's been found that they are it's a better care coordination approach that meets patients where they are. And then also, trying to actually streamline administrative processes. And so in New York, they have a personal assistant program that helps to support trying to kind of streamline the red tape and the issues that come with trying to roll these types of programs out. And then, I'll also just name 2 things quickly. Obviously, taking an intentional approach to addressing the social drivers of health and investing in supportive housing and addressing social needs that have also been found to improve health outcomes. And then lastly, what are the various ways in which we can leverage AI? We know that AI and machine learning can help to support predictive analytics. It can also address fraud detection and really really key in on taking a more personalized care coordination approach that can improve efficiency and reduce cost within Medicaid programs.
Okay. There's some elephants in the room. Let's see if you pick them up, Dr. Carter.
Yeah. So I'm going to take a slightly different approach. So when you look at, first of all, and this is, I think, where there are some opportunities. Okay. First of all, in the U.S., prices for everything in healthcare is skyrocket, right? So we look at, I remember a neighbor I had that when I lived in Europe, had a knee replacement. At around the same time my mom had a knee replacement, and in total cost of knee replacement was 5 to 6 times less than what my mom. My mom's out-of-pocket expense was more than what my neighbor paid. Also, we spend more time on sick care than health care. In the U.S., we treat folks when they're ill, okay, as opposed to more preventative care, public health, and systems that actually address the social determinants of health. The social determinants of health largely are ignored, and we talked about some of those. And again, we have a very complex profit-driven system. Let's face it. So in that profit-driven system, it does not guarantee access to care. And so the other aspect, again, by spending that's focused on treatment and not prevention, often folks are diagnosed late. And so basically the treatment required to get them from stage 4, stage 3 cancer, because we don't do effective preventative measures, we spend hundreds of thousands of dollars to get that patient. In many cases, it's too late and they die prematurely. So those are just some of the reasons I think that, and I think those are, I would say, some of the opportunities, with some of the policies and initiatives. I think there are some opportunities there specifically to address some of those complexities that I just described.
I thought I was going to have to put my two younger brothers here back in the cut because I didn't hear the buzzword. Thank you for redeeming yourself and mentioning preventive care, because that's my wheelhouse, and if I hadn't heard that, I would have an issue with you too. But what happened to universal health care? Why are we not having that conversation? I appreciate the both of you wanting to retain a uniquely American healthcare system, because, as I mentioned, the healthcare industry does drive the economy. It sustained the economy during COVID, and that's why it's so much more expensive than the rest of the world. But is there no conversation to be had about eschewing? If you talk about fraud and waste and efficiency, where's the conversation about universal healthcare? Every other industrialized nation on earth, except for the United States, does this. I'm time out, redouble. Back to you, Dr. Enya. You got to come back with it.
So listen, and I'm going to say this. I'm going to be candid. So the American culture, writ large, is I would argue is arrogance and entitled. We don't like to listen to other cultures, people that don't share the American values. And so despite the fact that other countries around the world, yes, have universal health care, which still has its challenges, but I do agree that if and when the United States can get to a point where there is the political will to act, because what we are talking about is literally dismantling what has been put in place, not the way that it's happening now, but we would have to upend and bring in an entire generation of individuals who also have an interest in this approach to actually try to turn the tide.
Man, come on. I'm calling you out on this one. This current administration has shown that you get the right people in office and you get control of the House, Senate, and the executive branch. You can do whatever you want to do on a dime. So I don't know if it's necessary to get an entire generation to appreciate health prevention and promotion. Look at the healthcare outcomes that exist in this country. Look at the amount of money that each family is being asked to spend on healthcare. People are hurting. And I agree with you 100% in that it is ludicrous to some extent that 80% of the population actually believes that our healthcare system is on point, if not the best in the world. But I think that we're a lot closer to doing it than we think. And I would argue that we should not give away the store so quickly and assume that it can't be done, because there's a whole lot of stuff being done right now that wasn't even on anybody's radar except for an individual that had it in his thoughts that this is the direction in which America should go. Jump back in there, Brother Carter. Let's see what you have to say on that.
Yeah. So when we look at, this is not a new concept, actually. So Truman proposed universal health care in the 40s, and it was largely not successful because of the fears of socialized medicine and that universal health care would somehow create a bigger government. And so I'll go back to my original points, right? So when you look in the United States, we spend $4.5 trillion, okay? That's a lot of money. That's a lot of folks basically getting rich off of healthcare. So until we make healthcare not a profitable, right? It's going to continue. So it's driven by profit. It's driven by opportunity. Healthcare, unlike other countries, healthcare is traded on the NASDAQ and Dow every day. You don't see that in Germany and Canada and other countries. And so again, you can take cost-cutting measures, okay, but that's going to typically result in less access to care unless you address the profitability issue in the country. And I think that's the overall big challenge. And I think that also folks typically think about it's a narrative that universal health care is going to reduce their quality of care. But the reality is that it's the costs that reduce their access to care and their quality of care, not the universal health care.
I'm going to bring back the Surgeon General team at some point in time, and we're going to flush out this entire topic because there's some nonsense going on, not in this conversation, but in general. This is where I remind you guys that the largest buildings in this country are insurance company buildings, okay? And this is where I remind you guys that before the Affordable Care Act came out, insurance companies were spending about 45 cents on the dollar in healthcare. And one of the key components of the Affordable Care Act was that 85 cents on the dollar had to be spent on direct patient care. There's plenty. The premise here is that there is so much money in the American healthcare system. You could have 2 universal healthcare systems in place to cover different tiers, and you still would have money left over. So let's leave that where it is. We're going to pick this conversation up because it's a good one. We have 2 more topics to cover in a pretty brief period of time. Number one, let's switch and talk to the people, because I'm always wanting to empower people in these conversations. So one of the things that's in the news that's painfully evident is the need for we the people to learn how to gather accurate information, to avoid misinformation and disinformation. What is it that's and this is actually a question that came up in the comments, what efforts are out there that help people avoid that, or are people really left to their own devices? You can't even say go to the CDC or FDA websites anymore, because those clearly are under governmental control and under the premise of political expediency instead of doing what the science tells us to do. So my question for both of you pretty quickly on this one, what's the best way for citizens today to stay informed? You go first, Dr. Carter, Brother Carter.
Yeah, I think you raised a good point. And I think it's actually one of the best ways is actually what we're doing right now as a group of professionals helping educate and basically having a conversation about the information. And also, folks not just getting their health information from TikTok and other ways they actually get, and then not perpetuating basically rumors and disinformation. I think that is so harmful, because if somebody hears something that that they believe to be true, they have to hear the real truth, the other side of it, 40 times before they believe it. So it's critical for us not to spread information that doesn't make sense. And so, and again, it's going to be tricky on how you get accurate information because there's a lot of bad information out there, but we have to do more of these types of activities, trusted professionals without skin in the game to help educate the population.
Yeah, I was going to say that back on the vaccine conversation. A lie circulates 100 times before the truth gets out the chair, right? Brother Enya, go for it.
Yeah, just quickly, but I just wanted to double back on the universal healthcare coverage piece. I stand on the fact that it is, from a civic engagement standpoint, it's going to be important to create a pipeline for individuals to get into key positions to turn the tide. And so, yes, we can do it now, yes, but I'm playing a long game as well. So that's it. Using trusted, nonpartisan news sources, NPR, PBS NewsHour, the Associated Press, Reuters, and
All of
then
which have their funding being taken away right now.
exactly right. Okay, right. And so then looking at policy, looking at which is part of the intentional whitewashing of history and the intentional keeping people ignorant, which is why this question is being asked. So the policy specific sources: KFF Health News, Political Pro, Health Affairs, Stat News, and then government sites, which there's actually no trust now in what's there. Those are things that I would put out there. But I will say that there's something to be said about teaching our families, our children, how to think critically, how to consume content in a critical way, how to take a balanced approach to consuming not just news writ large, but news that is balanced. And so that is critically that is critically important to model and to teach.
Yeah.
Podcast, so again, if the groundwork has been laid for you to think critically about the information that you are consuming, you're better able to ask critical questions of that content and to actually come up with your own ideas and your own argument based upon the balanced approach that you ideally should have taken to consume the content.
Brother, that is such an intelligent answer that it smacks of being elitist. In a country with a 25% illiteracy rate, here's how I answer the question, because it's consistent with what people do now. Whoever your trusted messengers are going to determine whether you view information as misinformation or not. Disinformation, obviously, something is being imposed upon you, but maybe the way we turn the tide is to make more prominent the voices of actual information. I don't know how many people out there are going to watch this podcast or are willing to listen to any hour-long podcast or webinar. So it remains to be seen. The way I respond is pretty simple. People whose science can be filtered through a political prism aren't discussing science. And at the end of the day, people have to identify it in the way in which you very clearly identified. You need to find trusted messengers and trusted sources and hang your hat on it. And that's really what it comes down to. And the work that is involved in doing that really is in identifying what trusted sources actually exist anymore. So we'll see. One of the things you did, you actually got on our last question, and that's what I can't do any conversation without talking about preventive health and self-empowerment, and the goal of what people can do within their own families and within their own communities to be empowered and to protect themselves and to be better stewards of their own healthcare. That's where the rubber hits the road. And I'll let you see if you have any final comments on that. You already spoke to it pretty well, Brother Enya. Go for it.
Yeah. So a quote that comes to mind is, "An informed mind is the first line of defense." And so, yes, at the risk of sounding elitist, I think it's, I'm taking the approach that it's important to lift as I climb. And so, yes, so staying up to date on our rights, learning financial literacy in terms of debt, credit, insurance, wealth strategies, learning how to speak up for yourself, because silence can be misread as agreement. And so it's learning how to self-advocate and to share your story in a way that resonates with different audiences. There's safety in community and there's strength in numbers. And so I think it's important to be able to hold space for these types of conversations, which hopefully will facilitate people in the community to be able to seek out the best resources possible.
Let me be clear. I was giving you a compliment in the vein of when Obama was accused by a few Southern senators of being elitist because he suggested that everyone should have a college education. You will never hear me criticize anyone for being intelligent, well-informed, and well-presenting in the way in which you are, sir. So don't get that twisted, please. Let me clarify that. On to you, Brother Carter.
Yes, no, this has been a great conversation. And I'll just hit on one other aspect of information. It's and that is critical for folks if they have questions to discuss what they're considering doing with their healthcare provider. I think, and then the healthcare provider would be able to hopefully redirect their thinking. So specifically around their health, and I'll hit on something else as well. Self-education, critical thinking is something that we have to do more effectively, because that allow individuals to engage their healthcare providers in a more in-depth conversation about their own health and about their own risk. And so I think because again, with the plethora of information, disinformation, just fundamentally lies out there, as my grandmother used to say, alternative facts. We really have to do our best. And again, it's not us, the educated, elitist group. It's really the majority of our community that we're responsible for. And we have to do everything we possibly can to continue to provide maximal outreach. We got to dedicate a certain percentage of our time to ensure that folks don't get left behind. Because I think one of the things that you can walk away from this conversation tonight, we're at a significant risk of a large percentage of our population being farther left behind financially, health outcomes perspective. And I think you hit on something else as well, brother. Just overall greater morbidity and mortality. And we have to do what we can to ensure our fraternity was founded on those principles. And so we got to reshape how we think. We also have to be voices. We can't be afraid, of what might happen. Just think if Brother King and all of our brothers that marched to get us to where we are now, where we could get educated, we can all of a sudden say, well, I got mine. Now I'm not going to take and assume any risk to ensure that we're not left behind and further pushed in the corner. I'll stop there.
Yeah, thank you both for those, especially for those last comments. You're both on point, and we have to be the message as well as the messengers. And I love the concept of critical thinking, because it's not where you start, but it's where you finish. And, as a physician, I've had a long enough career now to where people simply at one point in time came in, plopped down in a chair and did what they were told, to where now, everybody's Dr. Google. I think part of that responsibility and part of the path that we have to take in order to get people to be critical thinkers is to recognize that they're not critical thinkers today. They are subject to TikTok culture and healthcare that's provided through a political lens. We have to empower people to be stewards of their own health. We have to teach them what to look for, teach them how to be critical thinkers, and to show them. One other comment that it came through that I endorse 100% is Google Truth Check. It's a great place to know disinformation and misinformation, and you can do it at any point in time on matters of health or otherwise. So I hope that you have found this conversation interesting, stimulating, and informative. And I hope that you continue to log in when we do these webinars on a monthly basis and occasionally in between. And once again, on behalf of just two esteemed, very powerful public health professionals, Brother Dr. Zenia and Brother Dr. Carter, and the rest of the Deputy Surgeon General, of course, and our Board of Directors and our General President, Brother Lucian Metellus, I want to thank you for being with us this evening. We will see you soon. Good night and God bless. Take care.